For the diabetic food, we have lots of techniques available. At the end, you can use all what you're used to and what you can do in your institution. We have the classical techniques like recanalization, stenting, PTA, drug-eluting PTA, and so on. But we also have more dedicated techniques for the diabetic and for the lower leg, especially like the pedal loop technique, the retrograde access technique, or even the venous arterialization for your patients. It depends on the imaging before what kind of patient should land in your Ranger suite. We try always to have some kind of imaging before. In the diabetic patients, we prefer MR imaging since you don't have the problem with the calcifications in the lower leg. When you do CT angiography, you also often have this. You have, in many cases, the problems that there are so heavy artifacts in the lower leg vessels that you don't see anything. So at the end, many patients, we also do some kind of diagnostic angio with the possibility to do in the same session a PTA, for example, a drug-eluting PTA, recanalization, and so on. The current evidence supporting interventional radiology techniques in diabetic patients, to be honest, is almost nothing or is very, very low. And we definitely have to create this evidence. When you look at the guidelines, there are recommendations to do and to use modern and new techniques, but the evidence is really low. When you think about diabetic patients, you just have to focus especially on one website. It's the International Working Group for the Diabetic Food. You find the website on the internet, and there are excellent guidelines regarding the diagnosis and treatment of these patients. For the diabetic patients, the most important thing is to have an interdisciplinary approach. The treatment should not be centered to one discipline, for example, to surgery or internal medicine or interventional radiology. They all have to work together for the patient in order to have the best success and the best result for the patient. In other parts of medicine, when you think on oncology, we already have these teams. We have our tumor boards. We discuss all together the disease of the patient and how to get the best result for the patient. In some other parts, in our institution also, for example, for the diabetic patients, we do not have yet such boards, but I think this would be very important, especially for this type of patients.